Good morning, everyone, and welcome to the Gulf Intervention Society meeting in the year 2025. It's really our pleasure actually to be with all of you here and this wonderful event that's gathering the most experienced and experts in the field of intervention in the Middle East and actually in the world. And this year is a fantastic year that we have a group of experts actually here, and I have the pleasure to be giving this and moderating this session. So my name is Tariq Al-Hussein. I'm a cardiologist. I'm with a special interest in echocardiography. And to my right side here, I have a group of wonderful people. I have Dr.
Zakaria bin Musa, head of Echo Lab at Prince Sultan Cardiac Center, interventional echocardiography.
Welcome to Dubai.
Thank you.
Dr. Sundus Samargandi, interventional structural cardiologist in BSCC Riyadh, Saudi Arabia. Pleasure.
Actually, our pleasure actually to be with all of you here. So before we go ahead, so how do you find the meeting so far with the lectures?
So far it's an amazing meeting, a great turnout of candidates and people. In addition, a very powerful scientific program, been distributed by multiple rooms, very active exhibition, simulation, training village, everything is just up to the 100% amazing.
That's really wonderful. What about you?
I think it's a great opportunity to be here with this really prestigious meeting. Scientific program is really very great, and the sitting as well, organization is very great.
So as we go forward, of course we will have a very wonderful discussion. So our theme today is to discuss about tricuspid valve intervention. This is really a field that's been growing recently, and now most of the big cardiac centers are adopting interventional procedures that are done to fix the tricuspid valve. So for many years, as we know, the tricuspid valve was called the forgotten valve. So whenever we talk about the right side of the heart, it's almost always neglected, has been for many years. So the focus is always on the left side, if you do agree on that.
Yeah.
So more recently, there is more attention that's been given to the tricuspid valve. Can you tell me from your perspective, why do you think the tricuspid valve, now it gets all this attention?
There's many factors that plays a role that why did the tricuspid valve draw attention in the last few years. One of them, the burden of the disease with the aging population and the increasing in the life expectancy of the population in general in many countries. So as we age, now we're seeing the ramification of the tricuspid valve coming with vengeance. In addition to that, a few years ago, 20 years ago, some trials that came not giving it solo, but rate versus rhythm, and now we're seeing a tsunami, as Dr. Zakaria has mentioned to me, of atrial TR coming. Thirdly is the progression in the last 20 years when it comes to transcatheter management in the left side of the heart, giving hopes that, we're not in lost cause anymore, or, the surgical outcome, though we know from the data that we have for the last 25 years, great. Now there is hope in the high risk or inoperable cases that transcatheter approaches may have a glimpse of hope for those patients to improve their quality of life, or in longer term, decrease their heart failure hospitalization. And finally, the improvement of the medical therapy that lead us optimize and putting this all together.
Okay, that's wonderful. So what about you, Zakaria?
I remember when I started my training in 2008, we were seeing a patient with right-sided heart failure and severe TR maybe once in every 6 months, one patient every 6 months. Now, I can tell you that maybe 30-40% of the inpatient, those patients, hospitalized patients, is related to severe TR and right-sided heart failure. So yes, there is increase in presentation of the patients coming to the hospital with the right-sided heart failure related to severe TR. Probably related to, like what Dr. Sundus, mostly to atrial fibrillation, also left-sided lesions that ends up with right-sided heart failure, different causes, one of the major factor is that we know that we don't have a medical treatment for right ventricular failure, or let's say dysfunction. And usually it will progress slowly over years, and eventually they will present with you with right side heart failure. So there is increase in the number, and then we are understanding better the tricuspid valve. In the last few years, there has been a lot of work in understanding the morphology, anatomy, mechanism of severe TR, and then more devices are available, or more option of treatment available for treating these patients. Before, as I said, in 2008, we don't have any treatment modalities or options for those patients. Nowadays, it's available, and that encourage people to be more actively involved in tricuspid valve treatment.
Okay, that's wonderful. So my understanding that Prince Sultan Cardiac Center has been the leading center in terms of volume, in terms of reputation. It's well built over the last 4 decades, and I do believe that you do have the highest volume for structural intervention as for cardiac surgery as well. So that's really, I think you are enriching also your experience building up with that. So far, what are the tricuspid interventions that you are doing there?
Currently, the options that we have in our center, and generally in the Gulf region, is edge-to-edge repair using either platforms, either the Abbott platform or the Edward platform. Secondly, valve-in-valves, even robotic or minimally invasive tricuspid repair or replacement. The TTVR or the valve replacement transcatheter usage has been approved by many FDAs in the region, and some countries has already started it in Qatar and Oman. Saudi Arabia is following through. We're expecting in 2026 we will see more of TTVR cases to come through. In addition to that, some of late stage cases, we have been improving the bicaval approach of a tric valve, where have been implanted also. So these are basically the percutaneous and the surgical available treatment currently in the region and in PSCC in specific.
Okay, that's really wonderful. So also my understanding for the innovations that are growing in the imaging part. So the echo has gone through many stages, as we know. We started with the M mode, and then later we have the 2D echo, and more lately we have the advanced 3D with the 4D as well. Okay, by imaging and getting 3D nice images with actually during time and live images. So that enhanced the quality of imaging of the tricuspid valve, and as you said earlier, also the better understanding of the etiology and the exact mechanism where you can intervene. So where do you see AI, for example? A lot of people now, they talk about AI. So do you see AI has any place or any role in improvement in the tricuspid valve imaging?
Well, any advancement in technology, it will be reflected in treatment feasibility and improving the outcome. Yet, it is a bit just the start, but it will take its time to get, let's say, more involved in the treatment options. We have different modality, like what you mentioned, the 3D multi-planar reconstruction and the X-plane. That helped us a lot in developing the structural intervention. I'm expecting more to come, like, for example, the fusion imaging, where you fuse the fluoroscopy and echocardiography on the same screen. That helped a lot in better outcome and easier, let's say, procedural techniques. The AI, we are expecting it to be also to get the things better and easier, but we'll see how things will go.
So our job will be secured for another few years, or you think AI will replace us one day?
I believe tens of years.
10 years? So that's good.
No, tens.
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 Oh.
Tens. The human factor is there. I don't believe it will be replaced. Yes, technology will help, but I do believe that the human factor will stay longer.
Longer to them.
Yeah.
That's good for us.
It's still needed.
Okay, so we will also touch base on the work harmony, okay, between the interventionist and the echocardiographer in the cath lab. So how do you find the dynamics about working together? So who is the leader and who is the boss?
There is no boss in there except the patient. Okay, so having a very dynamic back and forth communication, let's say, between the interventionist and the imager and the anesthesiologist is very crucial, and the nursing staff also. It's the whole team coming together. It's not like one person show. Maybe in the left side used to say, like, I did the procedure, I did the PCI, I put the valve, and maybe you will see something. But in the tricuspid, it's a very tricky valve, where there's lots of intersection and intercommunication that's happening. So a very clear communication line should be a closed loop between all the the people that we mentioned. In addition, anesthesia has a role because they can also adjust their anesthesia setting during the procedure to help you have better image. The nursing care before and after has a very crucial role in the follow-up of the patient. And finally, of course, in the outpatient setting, heart failure physician and team, they have a major role to continue, because the success, it's a very chronic valve that takes years to develop symptoms, and it will take years to improve these symptoms. Not only the success of the interprocedural, but the follow-up is a very crucial element. So you have to have a flow dynamic communication by all teams.
Okay, so Dr. Zakaria, how about the dynamics?
I believe that the dynamics start before the cath lab. The team has to sit before starting the procedure, making a plan of the treatment strategy, and then during the procedure itself, it's a mutual interaction between the different parts of the team. Everyone has to express his opinion, his ideas freely, and they have to have an agreement. If I, as an imager, I find any one of the team who is not happy, I have to please him, I have to bring better images to make him convinced and make him happy. If the interventionist, if the imager is not happy with any step of the procedure, the interventionist has to listen and make everyone comfortable. Let's say that any position, any doubt, we have to have an agreement. We have to have a sort of, agreement or
harmony
about the result, about a confident, a convenient, that they are happy. We are sure that we are at the good point. Everybody has to be convinced that we are good. That's, I think, how things should go in intra-procedural. And then post-procedure, like what Dr. Ascendus mentioned, that we should involve the heart failure team, the primary physician, the nursing, everyone is important in the success of these procedures.
That's great. So it's really this conversation can take longer. Having two beautiful guests, both of you actually here, it's been wonderful, really, and fantastic moment. So, as they all said here, that the tricuspid valve, it's an area of innovation. More devices are expected to come. More advancement in the technology, and this is very important to have a center of excellence wherever all the cases are referred, so they can build the experience, and you can train also younger generation also in the future, rather than having it scattered, one case there and one case there. So I think Prince Sultan Cardiac Center has the milieu to really attract all of these, and most of the referrals, I do remember that we've sent you also 2 patients from our hospital, and they did very well after the procedure. So also we talked about the importance of the hemodynamics, the team dynamics. Okay, this is very important to keep everybody happy and satisfied with a constructive feedback in the cath lab. So this is very important and essential. So as a closing remark, it was really a fantastic moment actually here to have Dr. Sundus, the interventional cardiologist, and Dr. Zakaria bin Musa, consultant interventional echocardiography, and myself, Dr. Tariq Al-Hussein. It's really a pleasure and to be with all of you here. And I hope you enjoy your stay here in Dubai, and also to continue with the wonderful sessions that we have here in the Gulf Intervention Society. I'm looking forward also to have another meeting with you very soon in the very near future.
Inshallah.
Thank you very much. Thank you very much.
Thank you, Dr.
Thank you
Lai.
very much.
Have a good one, everyone.
Thank you.